Our final speaker for tonight is Dr. John Semple. He is the head of the Division of Plastic Surgery at Women's College Hospital and a professor in the Department of Surgery at the University of Toronto. He is recognized nationally and internationally as a surgical clinical leader in breast reconstruction. His presentation today is titled Nipple Reconstruction and Refining Results. Dr. John Semple, Nipple Reconstruction and Refining the Results.
Thanks, Elaine. I just want to start by saying how amazing the patient stories are. They're really quite remarkable and really important, I think, and I like the way it's integrated into the talks. It's been very special because generally when we stand up as plastic surgeons, it's plastic surgeon, plastic surgeon, plastic surgeon. So to hear the feedback is great. So thank you for all of that. So I'm talking about nipple reconstruction and some of the refining results. The overall reconstructive goals you've heard about already: ample soft tissue coverage, proper contour and shape to the breast mound, symmetry with the other breast, realistic nipple areola complex with correct placement, and a high degree of patient satisfaction. And nipple areolar reconstruction is really just an option. And so many of the techniques now actually preserve the nipple, but about 50% of the patients that have the nipple taken will have it reconstructed. And we do this approximately 3 to 4 months after the actual breast mound is reconstructed. So it happens later. And there's really no window of opportunity. You can do this at any point beyond those 3 or 4 months. You can wait 5 years, you can wait 10 years, and there's no advantages one way or the other at that point. So there's no rush to make the decisions on when you have that nipple reconstruction. You might ask, well, why not do it at the same time to save that operation? But it's actually quite difficult to do that because as you know, in that criteria for a good result, you have to place them exactly where they're supposed to be. And there has to be good symmetry. And if the patient is lying down and there's swelling right after the reconstruction, you can't really tell where that's supposed to go. So we always wait till things settle, till the swelling goes down, and then we do the reconstruction. There are multiple methods that we'll cover. For the nipple itself, we'll do nipple sharing. You can do grafts or flaps and also injectables. And for the areola, there's grafts and tattooing. This is what we call flaps and grafts on this section. I apologize for the intraoperative slide, but it's not too bad, seriously. So you can see on the smaller picture, we actually have placed the actual position for the nipple, and then we actually, you can see this part here, that's actually, it's a bit like origami for skin in that sense, that we can keep it attached in the center and lift it up and turn it into a small tube, and that becomes the actual nipple. And you can see here, the nipple is now trimmed and looks like a nipple as in a tube. And the skin graft is a full thickness graft, we call it, and it can be taken from a number of different places and then sutured into the position. And this is it about a year later where the scars have healed. And this is in an autogenous flap. And you can see that their projection is still quite good. And I've seen patients as long as 20, 25 years, and they still have a reasonable projection at that point with this particular technique. This is tattooing, and I was just talking to Dr. Brown beforehand, and we used to do tattooing here, but we stopped pretty quickly after we saw what people were doing in the community, and they do such a better job. And this specific training for medical tattooing is done in stages, and there's people out there in their booths that you can talk to. But these are 3D tattooing, and the results are really quite remarkable. And you can see that even the amount of detail that goes into that, and it takes several times to do it, but it works out very well. So with the nipple reconstruction, there can be downsides to that. You can get nipple necrosis, which is quite rare. It can flatten out a bit. There can be fading of the pigment or incorrect nipple placement, and that's what we were talking about just recently. And how long does the nipple reconstruction actually last? So over the longer you wait, there may need to be different refinements made, and even with tattooing, you may need it re-tattooed at a later time because tattoos do fade as well. And what about sensation? Sensation is not really part of that reconstruction, so the nipple always stays numb. You may have some protective sensation that creeps back into it, but never like the real nipple was in the beginning. This is a patient that had combined techniques of flaps and grafts, but also had tattooing. When the tattooing started to fade, she had the entire nipple complex tattooed again, and this is a great option of the combined techniques. My patients sort of come back and show me what they've done with other types of tattooing to hide the scar. You can see that the nipple itself has faded quite a bit here, but there are lots of creative ways of dealing with tattoos. This is another patient that was very creative in terms of the types of tattooing that she was wanting to get. This is a patient, we call it nipple sharing. So if the nipple is large enough, we can actually take part of the other nipple and share it with the other side. This patient had bilateral reconstruction with implants, but she had a lumpectomy down here that pulled the nipple down, so we were going to try to replace that or move it around a little bit. So this patient, you can see what we've been doing here. We're shifting the nipple up on the right side, but taking part of that right nipple and using it as a graft for the left nipple, so it keeps the pigment, and then using a graft for the areola. And just showing you the final result years down the road with fairly good symmetry and placement and of what it looked like before and after. So the opposite breast, you can be a balancing procedure, a reduction, a lift or a mastopexy, or an augmentation if it's a unilateral. And this can be different for bilateral breast reduction, but there's always a chance of wanting to do an extra couple of cases or smaller things for refining the reconstruction further down the road. Again, this is just showing a patient with asymmetry that's had a breast reduction. Again, another patient that had a lumpectomy where a bilateral breast reduction was performed for improved symmetry. And a patient that had a tissue expander placed here, but was very small on the other side, and we did an augmentation to improve the appearance down the road, and she was quite happy with the results from that. I'll talk a little bit about sensation. So it's important to know that while we can reconstruct the nipple does not have that sensation as it did before. And up to about 30 to 60% of patients will have sensation that creeps back into that area, but it never actually becomes like it was before. And there's a lot, this is one of the sort of frontier areas of breast reconstruction where people are now looking at ways of finding those nerves, and through tracing the nerves. This is more common in autogenous tissue, not so much with implants, although there's steps being taken in that as well. But people are looking for the nerves that supply the nipple that can be identified, but it has to be, we have to be positive that it's not going through areas of the cancer. So those are the sort of the limitations we have. But I think there's a very strong interest in wanting to, if not preserve sensation, but actually find ways to re-innervate those areas or the nipple and the breast with things like nerve grafts, things like, or different methods of reconstruction that may follow that. So overall, there's lots of options for nipple reconstruction if that's what you choose to do. And again, we want a realistic nipple areola complex with correct placement, and most of all, a high degree of patient satisfaction. Thank you very much.